Hello, my name's Tiffany Cashdollar, and I'm a student at Maryville University in the DNP program, and today I'm presenting on my project, De-escalation strategies for youth in one inpatient residential facility. My committee members consist of Professor Teresa Galakatos, who is an associate professor of nursing at Maryville University in St. Louis, Missouri. My community member is Nicole Thurrett, a certified registered nurse practitioner from Bradford, Pennsylvania. And my second reader is Professor Maria Snell, assistant professor of nursing at Maryville University of St. Louis, Missouri. Prior to going into details about my scholarly project, I'd like to share a little bit about myself and where I work. I'm a registered nurse and have worked in a residential treatment facility, also known as an RTF, for the last 3.5 years. The RTF I'm employed at is for pediatric individuals with intellectual disability, along with mental health or behavioral health concerns and/or diagnosis. In this client population, they are often aggressive, both verbally and physically. Behaviors are seen daily. My job is to provide a safe and healing environment and work alongside a multidisciplinary team to rehabilitate these individuals with appropriate coping mechanisms to get them home and back into the community safety. Due to the nature of the individuals of this placement, the residential treatment facility, the company, and location will remain confidentiality. Children with emotional and behavioral challenges often need to be cared for in residential treatment facilities. Diagnoses that can be seen in these individuals can include attention deficit disorder, disruptive mood dysregulation disorder, depression, anxiety, post-traumatic stress disorder, and much more. These children receive medication management, cognitive behavioral therapy, and observed in order to promote a safe, quality environment. Behavioral events can occur in residential treatment facilities and range from verbal outbursts to physical aggression to self-injurious behaviors. These events impact the safety of children and staff and all around in the environment. When the safety is in question, often the use of physical restraints are required. The longer a child stays in an RTF, it is more likely they will require physical restraints. Physical restraints: out of 13,000 restraints, 10% or 1,300 resulted in severe injury of the child. The reference for this is Kitab et al. 2018. The negative consequences of physical restraints impacts an individual's treatment progress. This can make it difficult for staff to create and follow through with a treatment plan for each individual child. Children with trauma already have a lack of trusting naturally from the previous life experiences. Once a physical restraint is used, staff must work really hard to regain that individual's trust and therapeutic alliance throughout the remainder of the treatment. Again, the reference for this is Kitab et al. 2018. Strategies for early identification and de-escalation must be considered first and only as a last resort considered the use of physical restraints. Kitab et al. 2018. Studies have shown when staff receive education on de-escalation strategies, emotional regulation, trauma-informed care, individualized treatment plans, and proxemics, which are body language and facial expressions, changes in behavior and safe environment can be realized, as well as the need for use of physical restraint reduction. Slato et al. 2021. The purpose and aims of this DNP project was to create an educational intervention on de-escalation techniques and strategies for staff who care for adolescents with intellectual disability and/or behavioral difficulties, in order to reduce the use of physical restraints. As a nurse in this RTF, I have witnessed hundreds of physical restraints, many of which could have been avoided with proper de-escalation techniques. Many times, staff are suffering from burnout or need a quick remedy when a client is starting to become aggressive. The way staff respond can either help de-escalate a situation or can add fuel to a fire. The PICO question in nurses and direct support professional who care for youth in one RTF: how does behavior modification training compared to current standard practice impact outcomes, i.e. escalations, over a period of 10 weeks? The population is the nurses and direct support professional, Implementation is behavior modification training. Comparison is current practice. Outcomes escalation in youth, and our time frame is 10 weeks. In one study that spanned over 26 years, 79 deaths were related to physical restraint use. This was found in Nuno et al. 2021. At my RTF in 2021, there were 195 escalations, and approximately 11% resulted in physical restraints over a 3-month period. The significance of this project is that nurse-driven interventions can impact outcomes. Thus, the goal of this DMP project was to reduce escalations that result in physical restraint, injury, and potential further worsening of trauma. The theoretical framework is the framework for change. Despite the age of this citation for theoretical framework, it is one that is a primary reference that was selected over others based on the needs of this DNP project. Farrell and Shortell's framework for change model uses a multi-level approach which aligns with the team's approach in the RTF. This is individualized group, organization, system, and/or environment. Nursing and direct support professionals work as a team to provide safe and quality care. They work as a teamwork, organizational environment, and culture helps to optimize evidence-based treatment plans. In this section, I will present the literature reviewed and 3 themes that were identified: de-escalation, trauma, and environment. These 3 themes help support the importance of the scholarly project. Self-regulation is the ability to manage emotions during activities of daily living or something stressful. Failure to self-regulate results in the inability to cope with stressors, which can manifest as verbal or physical aggression, including an increase in stress, self-injurious behaviors, and/or depression. RTF staff provide help to those who are unable to cope or manage emotions and stressors on their own. Sometimes there may be a history of trauma or an exposure to violence that worsens this ability. I'll discuss this more in a few minutes. De-escalation strategies are preferred, yet physical restraints or seclusion may occur. Physical restraints can lead to injurious experiences by both staff and the individual being restrained. Instances of death, although very rare, have been reported. Recognizing and intervening signs include fast breathing, clenched fist, pacing, non-compliance that can occur before an outburst is critical. Understanding these coping skills, such as deep breathing exercises, taking a walk, meditating, exercising, can all help an individual de-escalate and prevent a possible trigger. These are unique for each patient. A trusted staff-patient relationship will help build de-escalation ability. A non-threatening body posture, maintaining a neutral face, and making slow movements reduce being seen as a threat by the individual who may enter a fight or flight response if they do see you as a threat. Trauma can occur for any individual. There are several types of trauma, including neglect, emotional physical abuse, and sexual abuse. Exposure to trauma can result in long-term effects, including behavioral outbursts, substance abuse, mental health concerns, difficulty in school, and difficulty in performing attachments with others. Knowing a patient's trauma history is critical for preventing escalation and re-traumatization. Providing a safe and calm environment is critical to both mental health and physical health, as it can impede or help patients arrive to their developmental goals. Access to basic needs, including food, housing, and social activities, can impact developmental milestones. RTF staff are responsible for keeping out of reach individuals, sharp objects, chemicals that can be ingested or sprayed on other individuals, and stationary furniture so that it cannot be weaponized during an outburst. It's important for staff to remain in control of the environment at all times. For For the methodology of this project, a retrospective chart review with a pre and post design was utilized. The setting was an RTF where participants were nurses and direct support professional staff who worked directly with clients at the site of implementation. IRB approval was received from Maryville University. An educational intervention was provided on escalation, de-escalation techniques, and nursing interventions. Inclusion criteria for this project: the EMR that was reviewed must include a client who was admitted pre and post intervention, documentation of escalated behavior, documentation of the outcome of the escalated behavior, documentation of how the de-escalated behavior was attempted to be de-escalated, documentation of a client's diagnosis of intellectual disability and or behavioral concerns. Exclusion criteria: EMRs were not included where clients discharged prior to the intervention and clients admitted post-intervention. A data collection sheet included escalation incidences and identified physical restraint use, de-escalation strategies, associated injuries, and narrative data from the staff and nursing. The narrative data from staff and nursing was a short statement on what de-escalation techniques were utilized, along if the technique and intervention was effective. There was no patient identifiers on this data collection sheet, and escalated behaviors were given a numerical number to be identified as. This data collection sheet was held on a password-protected Excel spreadsheet on a password protector computer that was stored in a locked office only accessible by this researcher. The data collection sheet was de-identified and met all inclusion criteria. This allowed the data collection sheet to be reliable, along with running appropriate data analysis tests to best understand the validity of the data obtained. The next section is going to go over the results of this project. Pre-intervention, there were 250 documented escalated behaviors. About 18.8%, or N equals 47, resulted in physical restraints. Post-intervention, there was a decrease in escalated behaviors from 250 to 206 documented escalated behaviors. However, there was 33.9%, or N equals 70, that resulted in physical restraints. That can be seen on the pre-intervention and post-intervention documented escalated behaviors in this chart. This chart compares pre and post physical restraint use, and you can see there was an increase of physical restraint use. The data collected to evaluate the outcomes of the escalated behaviors of physical restraints and the ability to de-escalate successfully was analyzed using a specific chi-square test known as a z-test of two different proportions. The independent variable was pre- and post-intervention, and the dependent variable was restraint use. With these variables, it was determined whether a relationship existed. A lower tail z-test for the difference of two proportions, a directional form of a chi-square test, was selected as the statistical test to run based on these variables to determine if there was a statistically significant difference between the pre- and post-intervention. This chart is the observed associations in the data analysis. The p-value of 0.9999 is greater than the significance level of 0.05. This meaning there is not sufficient information to suggest a decrease in the ratio from pre to post intervention. The observed association data continued onto these charts, showing a confidence interval suggests the true change in ratio from pre to post intervention. The achieved power of this study is 0.0201, which is considered low in strength. The next section is the discussion, implications, and recommendations. Throughout this project, this author experienced several limitations. These included time constraints, short staffing, and loss of potential data to admissions or discharges that did not fit the qualification for the EMR review. Potential bias was reviewed multiple times throughout this project to eliminate any potential misinformation or interpretation of the data. This author also created the implementation with generalizability with the hopes that this project can be implemented at any other place. A longer duration in data collection would provide a larger sample size. There was a high staff turnover rate along with being short-staffed. This led to many limitations as clients were unable to form trusting relationships with staff fully, and those staff that did work may have suffered burnout from working extra shifts. Lastly, clients admitted after the intervention or discharge prior to the data collection were completely excluded from the project as data collection was unable to adequately compare pre- and post-intervention for those clients. One of the unintended consequences of this project was staff termination or voluntary resignation from employment. As mentioned, one potential contextual element that interacted with the intervention was staff burnout and short staffing. The resignation and termination of staff possibly worsened this factor. On the other hand, new hires coming in post-intervention had to be educated on the intervention during their new hire training to prevent unintended consequences. The COVID-19 pandemic also affected the communication between the researcher and staff, as many had participated in the intervention via Zoom. Due to social distancing regulations, COVID-19 regulations also require staff to wear appropriate PPE when engaging with individuals in the facility. This limits the ability for nonverbal communication strategies and nonverbal empathy. Although there was no statistically significance in physical restraint reduction, the intervention did result in a decrease in escalation. The intervention provided the staff with techniques and strategies to identify a potential behavior prior to it becoming a behavioral crisis. Previously mentioned, this is an 8-bed facility. However, throughout this project, the census was not full at all times. During the duration of the intervention, there were multiple new admissions and discharges. Due to criteria needing to be admitted 10 weeks prior to the implementation and not being discharged until 10 weeks post-intervention, only 5 client EMRs were able to be utilized for data collection. This resulted in a lower sample size for both documented escalated behaviors and an increase in the amount of physical restraint use. Staff burnout was also an issue as the therapeutic relationships weren't able to be built and there was a decrease in motivation to change. This project has several implications for current practice and future research. There is limited research on the pediatric mental health population due to the vulnerability of this population. This project showed the importance of continued research on de-escalation techniques along with physical restraint reduction. The reduction in documented escalated behaviors showed the need in this one facility for staff education on de-escalation techniques, along with being educated on why these individuals may have aggressive behaviors. Continuing the educational intervention with staff future can potentially benefit future practice in this organization. Future research is needed, though, to understand the effectiveness of staffing intervention with the pediatric mental health population and de-escalation education. This project was shown there is a need for this evidence-based educational intervention aimed at staffing working directly with this population. Though the data only showed significance in the reduction of escalated behaviors, it still showed partial success of the implementation. This will impact practice by improving de-escalation techniques with staff utilizing in this residential treatment facility and potentially in the pediatric mental health population. The next step would be repeat this project for a longer duration of data collection. possibly in another residential treatment facility within this organization. Those results can then be compared to this project. Considering all potential factors that could possibly lead to the results of this project prior to repeating this project is important to allow for all possible best chances of a successful outcome. Attached are my references. You may pause to review them. I'd like to thank you. I'm happy to take your questions. Feel free to post your questions here in YouTube, or you may email your questions at tcashdollar1@live.maryville.edu. Thank you for listening. Have a great day.